Welcome back to another episode of Strive Sessions. My name is Jared. I'm a pharmacist here at Strive, and today we'll be going over sexual wellness and erectile function. Quick disclaimer before we get started, these statements have not been evaluated by the FDA and are not intended for medical advice, diagnosis, or treatment. This presentation is for educational purposes only. The information provided is based off current literature and clinical experience. Before we begin, we'll be going over and exploring a couple of root causes of erectile dysfunction and sexual dysfunction. We should be able to have confidence in traversing conversations with patients about ED and sexual wellness, and we should also be able to explain current care options with our patients. To start off, we'll be going over some facts and myths about erectile dysfunction. Firstly, erectile dysfunction is always physical. This is not the case. There are so many factors to take into consideration when talking about sexual dysfunction and erectile dysfunction. Things like emotional health, things like anxiety, depression, even relationship dynamics can have impacts on erectile dysfunction. Erectile dysfunction only happens in older men. We see that this is consistently not the case. There are patients under the age of 40 who are coming out and having erectile dysfunction. And there is not a one approach that works for everyone. There is no one size fits all. We have to take a multifaceted approach when approaching sexual dysfunction and erectile dysfunction. There's things like physical health, stress, lifestyle modifications, as well as pharmacological options that we have for these patients. With that being said, behind every conversation about sexual wellness is a person navigating vulnerability, identity, and the desire to feel whole again. Erectile dysfunction can happen for a variety of different reasons. They typically fall into three main categories. It could be physical, it could be emotional, and it can be mental or medication related as well. Erectile dysfunction is not always physical. Disruption in any one of those three parts can contribute to sexual dysfunction or erectile dysfunction. For example, a prior erectile dysfunction episode can lead to worry about performance and anxiety when performing. This can further impact ED episodes down the road, having that mental image or that mental doubt in the back of your head. Psychological factors can contribute up to 10 to 20% of total erectile dysfunction episodes and can either be the main cause or it can be a contributing cause to erectile dysfunction. Erectile dysfunction is getting younger, but the causes look different. While stress, performance anxiety, depression, relationship disturbances are all factors in erectile dysfunction, men are reporting more and more psychological reasonings like relationship factors, like stress, like anxiety, outside of just physiological issues with erectile dysfunction. This can further impact things like emotional damage, identity crisis. There's social withdrawal. Erectile dysfunction goes so much further than just the intimacy component. But there are also so many other components to take into consideration as well. Things like physiological and relationship factors, as we discussed, things like blood flow problems, hormonal changes as we age, metabolic health, nerve issues with people who are frequent smokers or alcohol consumption. Everyday habits, also contribute to erectile dysfunction. Things like having a good night's rest, limited exercise, or even frequent pornographic use or recreational drug use can impact erectile dysfunction and sexual wellness. As we discussed earlier, there is no one size fits all. It is important to take into consideration and take a multifaceted approach when treating erectile dysfunction. We should approach it from these key areas. Lifestyle interventions. Are we getting enough aerobic exercise? Are we getting proper nutrients, protein, vitamins, minerals? Are we implementing proper stress management, meditation, breathing exercises, going for those jogs, going to the gym to help alleviate that stress? Also, hormonal optimization. We know that as we age, testosterone levels tend to decline in men and women. And that can impact things like libido, things like mental health, things like muscle mass, bone density. And then there's also the psychosocial performance aspect as well. Having this mental image and having this fear and anxiety of not being able to perform or meet current standards of your partner, and then that just compounds even further. And of course, we have our combination regimens and our medication regimens that we can use to help assist these patients with erectile dysfunction and sexual wellness. It's important that we go over all of these factors with our patients. Currently, the American Urological Associations recommend shared decision making with our patients. They should be aware of all of their options and make an informed decision based off their options. That being said, we'll be going over our pharmacological opportunities and our options. Things like PDE5 inhibitors, dopamine agonists, hormonal regimens, peptides, and then lastly, intracavernosal injection options. So to start off, we're going to go with our tried and true PDE5 inhibitors. This shouldn't be new to anyone who's watching today. Phosphodiesterase 5 enzyme inhibitors will prevent the breakdown of CGMP, which helps relax the smooth muscle and allow it to flow with blood and vasodilation. It is important to keep in mind that this will not impact libido. There still needs to be some type of external sexual stimuli to promote that arousal. It also is also to take into consideration if they have existing health conditions, cardiovascular disease. If patients are on nitroglycerin, nitrates, this is contraindicated for PDE5 inhibitors because of their effect for hypotension and lowering blood pressure. Other potential side effects that we need to include when we're counseling our patients, things like flushing, headache, potential vision changes where greens might look like blues, or even lower back pain have been reported with PD5 inhibitors as well. Next, we have apomorphine. Apomorphine is a central acting dopamine D1 and D2 receptor agonist. It's going to work centrally to enhance this and stimulate the hypothalamic and limbic pathway. This is a great option for both men and women who have more psychological related sexual dysfunction. It's working on that reward pathway. Typically, we see it done sublingually. Why do we like it sublingually? We have a lot of limited enzymatic activity. It's a neutral pH, and the mouth is highly vascular. So it's going to be picked up by those blood vessels in the mouth and distributed throughout the rest of the body. It also may have some side effects associated with it, things like headache, dizziness, flushing. It's generally well tolerated otherwise. Next, we'll get into our bioidentical hormone replacement therapy, things like testosterone. Decrease in testosterone has been linked to a decrease in libido, sexual desire, muscle mass, bone density, mental health. Testosterone is a great option for both men and women. A study was performed in 2000 that took the total mean testosterone in men, and it showed that in 2000, we had a starting concentration of 605 in total testosterone and decreased to 451 in 2016. This can be related to a variety of different reasons. Reasons such as lifestyle, diet, stress, anxiety. There can be a lot of reasons why testosterone are decreasing in men throughout the decades. And as we discussed, the potential benefits go so much further than just sexual wellness and libido, sexual health, muscle mass, bone density, energy levels. Now, there are a variety of different ways we can supplement testosterone in our patients. Things like injections, sub-Q or intramuscular, which will typically vary based off the vehicle or oil that's being used in those. We have transdermal or topical, so creams being applied to thin skinned areas and oral or sublingual. Again, that mouth is so vascular and it's going to absorb so much medication. It makes it a great option for hormone replacement therapy. It will also bypass first pass metabolism. Frequency will vary depending on the route of administration you go with. Typically, we'll see daily for something like a troche or sublingually, or daily for transdermal, and maybe something like weekly for injections. It really does depend on the route of administration. When starting bioidentical hormone replacement therapy like testosterone, we do need to take in consideration labs. So, if a patient is considering hormone replacement therapy, they should be made aware that they do have to have baseline labs before they begin, and then typically a follow up lab 6 weeks later to assure that there's not super physiological levels of testosterone. And again, it's also having that conversation with your patient to ensure they're not reporting symptoms like side effects with the medication and that they are having symptomatic relief with low libido or sexual dysfunction. The next medication I want to review is bremelanotide. Bremelanotide, also known as PT141, is a melanocortin receptor agonist, primarily the MC4. This is going to work centrally, so in the brain and in the spinal cord. Typically, we see this as flipping the switch. So, this is going to work on the arousal pathway. When taking this medication, we do need to take into consideration a few things. It can be done sublingually, nasally. It can also be done as an injection. When it's being done as an injection, we do see higher bioavailability, so higher levels in the blood plasma concentration. When we see this, we do limit the amount that we can inject. This can be limitations such as no more than 8 times per month, for example, or no more than once every 24 hours. With nasal and things like sublingual dosing administrations, we don't carry that same risk or concern or limitation in terms of dosing, but it is something that we need to communicate with our patients. The reason why we have these limitations is there's a risk for hyperpigmentation since it's acting on melanocortin receptors as an agonist. If a patient starts to notice hyperpigmentation on this medication, it's important that we counsel them to make sure they discontinue it right away. Other adverse effects to take into consideration are things like flushing, headache, and injection site reactions as well. Next, we have oxytocin. Oxytocin shouldn't be new to any of us. It's commonly referred to the love hormone as the love hormone. It is commonly associated with things like intimacy, lactation, childbirth, fostering those connections in our relationships and our day to day lives. The benefit to oxytocin is it can enhance that libido by activating oxytocin receptors in the brain and in the spinal cord. This will enhance arousal and also enhance that satisfaction aspect with sexual function. We typically see this as sublingual or as a nasal spray as well. It's been shown to potentially improve things like migraines, anxiety, depression, weight loss, though the doses for these causes and for these reasons can vary. And for the today's purpose of today's topic, we'll keep with sexual wellness. There are certain considerations we need to take as well. Things like headaches have been reported, dizziness. There have been reports of uterine contractions in postpartum women. And also with nasal sprays, we always have that risk of nasal irritation, nosebleeds, that we should counsel our patients on as well. Next, we have intracavernosal injections, things like Trimix and Bimix. The components of Trimix include alprazolam, papaverine, and phentolamine. For Bimix, we lower that to just two ingredients, papaverine and phentolamine. The mechanism of action of these ingredients include vasodilation, smooth muscle relaxation, and they're primarily just relaxing that smooth muscle, allowing blood flow to come through in the cavernosa space. That being said, it's important that we counsel our patients on these types of injections. These are going to be injections done with subcutaneous insulin needles typically. These needles are going to be anywhere from 29 to 31 gauge, half inch in length. And if you're not counseling your patients, we run the risk of them potentially doing it closer to the tip or in the abdomen. We want to make sure if they're doing an intracavernosal injection, they're doing it anywhere from 2/3 or lower on the penis, typically at the 10 o'clock and 2 o'clock position to avoid the urethra. So having that initial follow-up visit where maybe we are explaining how to use it and making sure that they're finding the correct dose is important with these patients. Now, this is typically used if oral options and traditional options are no longer working for these patients. If they've tried their sildenafil, they've tried their tadalafil, their oxytocin, and nothing seems to be helping with erectile dysfunction, this is a great option. And when it works really well, guys. So again, making sure we're going through those injection techniques with our patient. They're aware of the risks. Risks like bruising can occur, fibrosis, so building up scar tissue with frequent use, and of course, priapism, making sure they're aware of how to handle priapism. So an erection lasting more than 4 hours. If they have an erection lasting anywhere from 2 to 3 hours, that's not intended. They can do something like an ice pack or a Sudafed to see if that helps. If it lasts an hour after that, typically we recommend an ER visit for drainage and treatment. Now, that being said, this is a great option for our older patients who have tried those oral options as well. And again, when offering those medication options, we also want to look at those lifestyle modifications. Modifications like, are they getting enough aerobic exercise? So, current World Health Organization recommends 150 minutes of aerobic exercise every week. Are they getting out there and getting their heart rate up to increase vascular health? And then also implementing, 2 to 3 days of resistance or strength building exercises as well is important. Nutritional standpoint, are they having a balanced diet? Mediterranean diets have been shown to help promote vascular health. Things like lumens, nuts, fish, dairy, extra virgin olive oil. Weight management for our patients who have excessive BMIs, who are, obese, who are overweight. There have been studies done in men that show BMI and men who had BMIs above 30, who have lost 10% of their total body weight, have shown improvements in erectile dysfunction. Are they having adequate sleep? Are they getting anywhere from 7 to 9 hours of sleep, of good quality, deep sleep? Really making sure they're feeling rested and having the opportunity to relax their nervous system. Are they promoting healthy stress reduction? As we discussed earlier, we can promote, meditation. Are they doing box breathing? Are they breathing exercises? And if it's severe enough, are we recommending additional help for these patients as well? And then, of course, the one that we all know, we have tobacco cessation. Tobacco, recreational drugs, excessive alcohol use have all been linked to poor vascular health, have all been linked to sexual dysfunction and erectile dysfunction. People who typically quit smoking up to 3 months later have shown improvements in vascular health and sexual dysfunction. So it never hurts to ask and see if they're ready to take that next step. With that being said, let's start having these difficult conversations and addressing root causes of sexual dysfunction and erectile dysfunction. Thank you for joining us. Remember to stick around for the live Q&A session at the end. And here we have our references in case you want to do a deeper dive on some of the topics we discussed today.